with me today is Professor Dr. Soumitra Kumar, sir. Sir is Senior Interventional Cardiologist from Kolkata. Welcome to CSI Studio, sir. So today you spoke on a very important and relevant topic on mitral regurgitation and role of echocardiography in the diagnosis. So what is the key investigation to diagnose MR in current scenario, sir?
In fact, once you diagnose a patient likely to be suffering from mitral regurgitation clinically, the first investigation to be done is, of course, a simple 2D transthoracic echocardiography, because that will give you, that will confirm the diagnosis of mitral regurgitation, tell us about its etiology, tell us about the morphology of the mitral valve apparatus and the severity of the mitral regurgitation. And the severity is also judged by the left atrial, left ventricular dimensions. We can estimate the left atrial pressure and other things, and pulmonary arterial hypertension. So it will give a diagnosis in totality.
Okay.
And then we can, if in some cases, further investigations may be required.
Correct. So other than echo, sir, what are the other investigations in selected few patients which may be helpful?
Now, one of the advancements of transthoracic echo is transesophageal echo, which we have to do in good number of cases just to have a better look at the mitral valve apparatus. And transesophageal echo can again be 2D or 3D. And 3D transesophageal echo, or for that matter even transthoracic 3D echo, often gives echocardiographer the same view which a surgeon has in the operative room.
Okay.
So it can be as good as that. Everyone has the echocardiographer can give us an idea about the three scallops of the two mitral leaflets, which one is prolapsing, and it gives us an idea about the chordia and other things. So before the surgeon walks into the operative room, he or she can have a good idea about whether to go for mitral valve repair or mitral valve replacement.
So will the experience of radiologist who has done the echo make a difference in the reporting of the disease?
First of all, radiologists are not competent to do the echocardiography, the MR study. So it is the cardiologist who has to do it, because a cardiologist is the only person competent enough to make a diagnosis of MR in totality, because that is a very technical thing. And in fact, if you want to test the skill and the knowledge of a cardiologist in terms of his understanding of
so how important is the skill of the cardiologist or physician who is doing the echocardiography for detection of MR or other valvular disorders?
Very important, because number one is the echocardiographic skill. He has to acquire the images very perfectly, be it transthoracic or transesophageal. So one skill is that. Number two, he needs to have a perfect understanding of the cardiac anatomy, physiology and hemodynamics, because unless he has that, total interpretation will be faulty. So as I said, it is an acid test for the total cardiological skill, knowledge, whatever the intuition of a cardiologist.
Any one or two tips you would like to give to your fellow physicians or cardiologists while doing an echo for an MR? What are the 2-3 things they should keep in mind?
Number one, always whenever you are diagnosing a valvular heart disease or a ischemic heart disease or a cardiomyopathy, the commonest valvular lesion you are likely to come across is a mitral regurgitation. So do look for it, and look for it in several windows, because it may not be so evident in parasternal long axis view. You always go to the other views like the apical 4th chamber, apical 2 chamber and apical long axis views, because like angiography, MR is one entity which may not be totally unraveled in a single window.
Okay.
In order to have a full idea about the severity and the etiology of the MR, you need to inspect it in more than one windows. So
Okay.
that should be the tip I would like to offer.
So more than one window should be screened if they are not able to.
Yeah, and spend some time on it. It should not be a hasty inspection.
So all these patients will need a surgical intervention, or there is a medical approach to these patients as well?
No, there are definite clear-cut guidelines on that from both the European and the American societies, which we need to follow. So we should intervene whenever the MR is severe, or the patient is having symptoms. If the patient is asymptomatic, whenever the ejection fraction is less than 60%, or the LV end systolic dimension is more than 45 millimeter, so that is the broadly acknowledged criteria for even mitral valve repair or replacement, even in asymptomatic patients. And these days, we are trying to pick up the cases earlier with the application of tissue Doppler and strain imaging, so whereby we can pick up very early LV dysfunction.
So I think the bottom line in managing MR will be the diagnosis, which is the key thing, and properly done echo in a skilled hand is the way to go ahead to identify these lesions.
Definitely.
Thank you, sir. Thanks a lot for joining and sharing your views with us.
Now, one of the advancements of transthoracic echo is transesophageal echo, which we have to do in good number of cases just to have a better look at the